Well, good morning. I'm Dr. Robert Mosinger, and welcome you to today's talks of the Ogden Surgical Medical Society meeting. I want to express special appreciation to Teresa for printing these in a large font because I forgot my reading glasses. And I am going to, our first speaker today is Dr. Petronella Adomako. She's an infectious disease specialist who completed her internal medicine residency at Good Samaritan Hospital in Baltimore, Maryland, and her infectious disease fellowship at the Tulane University Infectious Disease Fellowship Program in New Orleans, Louisiana. She is board certified in both internal medicine and infectious diseases. Dr. Adomako is currently the Director of Infection Prevention, say that 5 times fast, and Antimicrobial Stewardship at McKay Hospital. She joined Intermountain Healthcare after 8 years of clinical and hospital practice with the medical specialties and the Franciscan Medical Specialists in Northwest Indiana. She's a member of the Infectious Disease Society of America and the American College of Physicians. She will give us an update on infectious diseases. And while she's coming up, I have to add, infectious diseases is always interesting. My 13-year-old daughter had to give a talk or a presentation in 7th grade class about a deadly animal. And after we kind of talked it over, she decided that she was going to talk about the most deadly animal on earth. And she did her presentation on the mosquito. And I think Dr. Adomako would have been proud.
Good morning, everyone, and I want to thank the organizers for inviting me to give this talk. Now, I will try not to be too ambitious and cover everything that's new in infectious diseases. So, let's go. What do I press? Okay. So I have no financial disclosures, and my objectives are not very original. At the end of the day, my goal is to try and tell you what's new in infectious diseases, a little bit of new information on new diseases and outbreaks that we have out there, and a little bit of information on new treatments. I'm going to divide the topic today into 3 sections. The first part would be about prevention, which would cover immunization. The second part would be about the organisms and some of the disease conditions. And finally, I want to talk about what's new in global infectious diseases. So let's go straight into it. In immunization, the Advisory Committee on Infectious Immunization Practices issued a new schedule for immunization in February of this year. And they came up with a table. To make things a little bit easier, my slide may be a little bit crowded, but the vaccines have now been arranged according to the age of administration on the left-hand side. Yeah, there we go. And then up top, you have the ages from left to right in ascending order. And they've also been color-coded. So the yellow bars are for the vaccines are recommended for those administration in those age groups. The green bars are for catch-up administration, and the purple bars are for those at risk of those infections, and those, therefore, you have to administer the vaccines at that age. So let's go back to it. Now, there's a separate bar. So what's new again? Aside from the color coding, you have the separate bar for meningococcal B vaccine, and there have been changes made to the footnote, and the changes at the footnotes are supposed to be read with the schedule. The changes, sorry, I keep on going back and forth. So the changes, some of the changes that have been made to hepatitis B. They've just made it easier to know when to test new infants for do serological testing on infants born to mothers with hepatitis B chronic infection. The changes to DTaP, just to let you know what to do if you administer a 4th dose accidentally. And then the Men B is just the introduction of the new bar. And the HP vaccine is just the introduction of the 9-valent vaccine. In terms of adult immunization, not a few changes. It's the same thing, same changes to the schedule. You have the color coding change. The only thing that has been mentioned here is that when it comes to pneumococcal vaccination, the time difference, for someone who receives the PCV13, you have to wait a year before you administer the polysaccharide vaccine, the 23 polysaccharide vaccine. Again, 9-valent is the same. MenB is also the same, just a new bar that has been introduced. I'm not going to talk about flu, so we'll move on. I hope I'm not. Is it too confusing? I hope not. Okay, so in terms of the organism, I decided to talk about what's new pertaining to some organisms and some disease conditions and some of the new guidelines that have been introduced. I figure that some of our physicians here will have a lot of primary care physicians, pediatricians, family practice physicians. I figure that you'll be seeing a fair number of pediatric patients. And in the British Medical Journal, they did a meta-analysis of about 58 studies from countries, OECD countries. The OECD countries are the countries in the Organization for Economic Cooperation and Development. And this is what they found. They found that there was increased resistance in the OECD countries, increased resistance of E. coli, of ampicillin to ampicillin about 53%. To trimethoprim or Bactrim, it was 23%. Augmentin or amoxicillin clavulanic acid, it was 8.2%. And ciprofloxacin, 2.6%. I presume that this is because we probably don't prescribe Cipro to the pediatric age population. Of note, however, is the fact that in non-OECD countries, the resistance was much higher. And this is thought that they can go to the pharmacist and get the medications over the counter, hence the higher incidence of resistance in those countries. So this is something you need to bear in mind when prescribing antibiotics for your patients, your pediatric patients. This is the resistant pattern we have. And we are seeing something similar over, at least with our intermountain antibiogram. We have a higher incidence of E. coli, or a higher incidence of E. coli resistance to ampicillin. So it's unicin or ampicillin sulbactam. So it's something you need to bear in mind when prescribing antibiotics for individuals with this organism. Back to organisms, hepatitis C. I'm sure you've all heard about what's new in hepatitis C. There are new medications available, and these are called the direct-acting antiretrovirals. And with the development of these new medications, we now have a cure for hepatitis C. Previously, the regimen for hepatitis C was peg interferon and ribavirin, the side effects of which were quite intolerable, so most people were not able to take it. And the rate of cure or sustained virologic repression was low, on account of which it wasn't something that we were prescribing on a regular basis. Now, with these new medications, based on the nature of the hepatitis C, we are able to sustain a cure in more than 90% of patients who are on this regimen. And this is because hepatitis C virus, once it infects you, it's not incorporated into the host genome, so it's easier to kill it off and thereby get rid of it. The medications, of course, are very expensive. The American Gastroenterology Association does recommend that everybody be given treatment, but the insurance companies are not all willing to do that as yet because of the expense involved. In terms of HIV, the new guidelines are that every single person who has HIV, irrespective of the stage, should be offered treatment. This is because the earlier they started on therapy, the decreased mortality they have. And then we also have HIV pre-exposure prophylaxis. This is offered to men who have sex with men, as well as disconjugate couples. And the medication used is called Truvada. They are supposed to take the medications on a daily basis. It's not that simple, though, as just prescribing the medication. You have to have counseling in place. These people are treated as if they basically have HIV. They have to be coming in on a regular basis to get lab work on a regular basis. They need to be tested for STDs when they start treatment. They need to be tested for STDs when they come back for follow-up. And they also need to be tested, and you take a history and physical examination, make sure that they don't have any evidence of acute HIV infection. Then the other new organisms. The CDC mentions that we now have a new bacteria causing Lyme disease. We all know of Lyme Bacteria, but now there's a new one discovered in the upper Midwest in the Mayo Clinic. They realized that about 6 of their patients who had symptoms that favored Lyme did not have the positive, or they had abnormal Lyme tests. And in further testing, they were able to come up with a new organism. It's called Borrelia mayonnae. This causes the same symptoms as the regular, Borrelia bacteria. However, they've noticed that the rash in Borrelia mayonnae tends to be more of a diffuse rash. The individuals also do have nausea and vomiting associated with their symptoms. And then we also have an outbreak going on in the upper Midwest with Escherichia anopheles. It's an organism that's found in the environment. It's not a very common pathogen, but they have noticed that in Wisconsin they had 60 patients, most of these conditions were hospital acquired. The organism was isolated from the blood and sometimes from the respiratory tract, but majority of this bacteria, or this, majority of the cases, it was isolated from the blood. Then we go on to guidelines. There have been new guidelines issued in the field of infectious diseases. We have new guidelines issued for infective endocarditis. They have noticed in terms of the organisms that cause infection, they have noticed that there has been an increased incidence of infection with Staphylococcus aureus. And there's a 5 to 25% risk of endocarditis with Staphylococcus bacteremia. So that means that if you have any individual who has Staphylococcus aureus isolated from the bloodstream, based on the risk factors or based on some of the complications, you need to make sure that you rule out endocarditis. And when you're trying to rule out endocarditis, you rule that out with an echocardiogram. You can start off with a transthoracic echocardiogram, but if you want to be cost effective, you just go directly to a transesophageal echocardiogram based on what you think your complications are. So for instance, if you have a patient with persistently positive blood cultures that are positive, let's say 4 days, 5 days out, you need to be worried about endocarditis. If you have an individual who is on hemodialysis with an indwelling catheter, you need to be worried about that. If you have signs of other organ involvement, such as abscesses in the abdomen, emboli to the brain, then certainly you need to be worried about endocarditis. The duration of antibiotics has also been made clear. It should be counted from the first negative blood culture. And when we are treating endocarditis, it's usually 6 weeks on the average, but it can range anywhere from 2 to 6 weeks. But it should be counted from the first negative blood culture. Now, I'm focusing mainly on Staphylococcus aureus because that tends to be the usual suspect. In the past, the recommendation was to add gentamicin to whatever agent you were using. So if it was an MRSA, you use gentamicin with vancomycin. If it was MSSA, you use gentamicin with nafcillin. However, after further studies, they've noticed that it does not make any difference, and you actually have a higher incidence of kidney injury. So gentamicin is no longer recommended as synergy for Staphylococcus aureus bacteremia. However, when you have prosthetic valve, you have to use gentamicin and rifampin. The rationale for this is the biofilm that you have on the prosthetic valve. When you have any evidence of any involvement of prosthesis in an infection, the concern is that the bacteria stick onto the prosthesis and form a film over themselves. And it's very difficult to just use the regular anti-staphylococcal agents to get rid of that infection. The rifampin helps the agents to be able to penetrate the film and kill off the bacteria. And the gentamicin is also supposed to provide some synergy here in this situation. In terms of indications for early surgery, I think it's been made clearer. Now, early surgery it's basically during the initial hospitalization. So you would need early surgery if the patient has valvular dysfunction, if there's persistent bacteremia. So 5 days out, 7 days out, there's still, the blood cultures are still positive, and you've made sure that you've ruled out any other source of infection, you need to consider surgery at this stage. If you have a multi-drug resistant organism like MRSA, probably a multi-drug resistant gram-negative organism like Pseudomonas, Acinetobacter, E. coli, in those situations, you need to consider early surgery. However, I need to mention that it's not very common to have gram-negative organisms causing these multi-drug resistant gram-negative organisms causing endocarditis. The same thing applies to prosthetic valves as well. So I'm going on to talk about antimicrobial stewardship and multi-drug resistant organisms. These are some of the multi-drug resistant organisms we have out there. We have Acinetobacter, which tends to be resistant to a fair number of antibiotics. Usually, if you're lucky, Unicin or ampicillin sulbactam may be effective against it, maybe the tetracyclines, and usually the carbapenims. But we tend to see a fair number of Acinetobacter that is resistant to most of our antibiotics, except for the carbapenims, such as imipenem and meropenem. Then we have Pseudomonas. The only oral antibiotic effective against Pseudomonas are the fluoroquinolones. Nothing else is effective. And you can see situations where we have Pseudomonas that tends to be resistant to a large number of classes. It can be resistant to the fluoroquinolones, it can be resistant to the beta-lactams, and then we are left with only carbapenims and aminoglycosides. And I'm sure most of us are not using aminoglycosides on a regular basis because of the significant adverse effects associated with that. Then we have the ESBL organisms, are the extended spectrum beta-lactamase organisms, which are resistant again to almost everything except for the carbapenims, maybe sometimes Bactrim and levofluoroquinolones. Then we have the CREs, which we hope we don't see a lot of over here, but these are carbapenem-resistant enterobacteria. These are gram-negative organisms that are resistant to virtually everything we have. The only antibiotics that may be effective against these organisms are the aminoglycosides, that's gentamicin. Then there's something else called tigecycline. And then we have to go back into our armamentarium to get colistin. Now, you notice that almost all these medications that I have mentioned have severe adverse effects. The aminoglycosides can cause nephrotoxicity. They can cause ototoxicity. Colistin also comes with some of the same complications, nephrotoxicity and neurological toxicity. So those are not safe drugs for us to use. And they may not even be effective in these situations. So it's something we need to bear in mind. Then obviously we have MRSA. It's been around for so long that I think everybody's probably used to it now. There are still antibiotics effective against it, but they can cause significant diseases with a higher mortality. And we also have vancomycin-resistant enterococci. So the CDC states that at least in 2013, every year they estimate that about 2 million people get illnesses from these multi-drug resistant organisms. And you have about 23,000 deaths from that. Now we also talk about Clostridium difficile colitis, and we know prescription of antibiotics is one of the risk factors for that. And you have 250,000 illnesses from C. diff, and you can have deaths associated with that. And most of these, the high incidence of multi-drug resistant organisms and the high incidence of Clostridium difficile colitis is because of the antibiotic usage. CDC estimates that in about 50%, that's half the time, we are not prescribing antibiotics appropriately. And I'm sure primary care physicians, you see, do you have a patient who comes in that they have a cold? Most colds tend to be caused by viruses, so we do not need antibiotics for that. The body deals with that by itself, but the patient wants an antibiotic. If you don't give it, they're going to go somewhere else to get it. I know we have a new, medicine, where you can just call and FaceTime or go onto the computer and tell them that I have this going on. And there's a tendency to prescribe antibiotics in those situations. But more often than not, a case in point again, upper respiratory tract infections, most are caused by viruses. We do not need antibiotics for those situations. And this is just one map I got from the CDC website. This is one of the organisms, the CRE organisms, or we also call them Klebsiella pneumoniae, Enterobacteriae. Every state, almost every state in the US has had this organism isolated. And it is associated with high mortality once you become infected with it. Except for Idaho and Maine, they're good then. Maybe they don't prescribe antibiotics inappropriately. Can't say that for sure. So then we move on to antimicrobial stewardship guidelines. And because of the high incidence of multi-drug resistant organisms with the associated mortality and morbidity, the CDC has issued new guidelines to help with that. One part of the guidelines, it mentions pre-authorization, audit, and feedback, where you're going to put a system in place, make some antibiotics restricted, such that they need to talk with either the ID pharmacist, if you have one, the person in charge, a physician in charge of antimicrobial stewardship, an ID physician, to see whether they really need those antibiotics before you prescribe them. They also have the option where you have audit and feedback, where you can allow the physician to prescribe it, but the pharmacist would do an audit and tell the physician that probably looking at your cultures, you may not need this antibiotic, or you can narrow your antibiotic spectrum. So that's one of the guidelines to help decrease antibiotic usage in the hospital. They also recommend development of facility-specific guidelines with implementation. You need to involve the leadership of the hospital and your physician leadership to make sure that you have guidelines in place regarding the usage of antibiotics, so that, again, we don't prescribe antibiotic inappropriately. And I guess most of us now have EMRs. We can put things in place in the EMR, guiding physicians as to what antibiotics to use. So for instance, if you want to prescribe, let's say, piperacillin tazobactam, also known as Zosyn, they may put some questions in place. You have to answer those questions, and that will determine whether the patient actually needs it or not. And I know in the Intermountain Health System, we have our power plants with the Cerner system, where they have antibiotics for specific conditions. That's also something you can consider. And I know the SCIP guidelines, they have guidelines regarding use of perioperative antibiotics. So those are all things that can be included into the EMR to help decrease antibiotic usage. And moving on, you can also coordinate with the laboratory to help guide antibiotic usage. I snuck this in there. Well, this was in there already because I want to talk about procalcitonin, but I'll get to that later. Coordinating with the laboratory means that you're working with microbiology lab. You want to get your culture results as quickly as possible. Once they turn positive, you want to be notified immediately. You want to have things in place that can help you know what kind of organism that you're dealing with. I know, for instance, with Staphylococcus aureus, we have a PCR test that will tell you that this is MRSA or this is MSSA. So you can find that out within 24 hours. That helps decrease your usage of vancomycin. They can also tell you whether you're dealing with a multi-drug resistant organism such as an ESBL or a CRE. So again, that helps you narrow your antibiotic spectrum. We have the MRSA screen, nasal screen, nasal swab. One situation, for instance, if you have someone coming in with what you think is hospital-acquired pneumonia and you want to cover for MRSA, you can do a nasal swab. And the studies have shown that if your nasal swab is negative, it's unlikely that you have infection with MRSA. In this case, you can therefore discontinue the usage of VANC. Then you have procalcitonin. It's a study in progress. We still don't have guidelines. It is not included into the guidelines as to whether it can be used to guide treatment or duration of antibiotics for pneumonia. It is a substance that is produced in response to bacterial pneumonia and septic shock. It is not usually elevated when you have a viral infection, though in some cases it can happen, but that's not the case. So usually when it's elevated, you suspect that the individual has a bacterial infection. It should not be affected by steroids. And there are studies out there that shows that using procalcitonin can help decrease antibiotic use, it can help decrease hospital admissions, and it can also help decrease the length of stay. Tentatively, or for now, the thought is that if your level is greater than 0.25, you need to be on antibiotics. If it's less than 0.03, which is a normal, then you don't need to worry about antibiotic usage. So, I mean, they're hoping that somewhere in the future, with further guidelines, we may be able to use this to guide the duration of therapy, hoping that if it's trending down, you can say that, okay, just treat for 5 days or 7 days. So we move on to global health. We still have infectious disease epidemics out there. Even though we don't hear much in the news about them, they are still out there. So I don't know if you could call them new or not, but it's still something we need to worry about. Tuberculosis is still an epidemic, even though we may not see a lot of cases in Utah. Malaria is still a problem. In 2014, 214 million people acquired that infection, out of which about 430 people died from that. So it's still an ongoing epidemic that we need to worry about. HIV is still a problem. Since it was first identified, about 34 million people have died from that. It is estimated that greater than 35 million people do have the infection currently, majority of whom are in sub-Saharan Africa. Then we have our emerging viruses. We have Ebola, everybody knows about that, has heard about that. We know of MERS-CoV, that's Middle Eastern Respiratory Syndrome coronavirus, and we know about Zika, which is making the news now. In terms of Ebola, thankfully the outbreak has died, but we know that there was the largest outbreak in West Africa involving Guinea, Sierra Leone, and Liberia. About 26,000 individuals were infected, out of which about 11,000 died. So mortality of roughly 38 to 40%. We did have a few exported cases. As we know, we had a few in the, just one exported case in the US and locally transmitted, but that was it. Thankfully, it did not spread. And thankfully, it's died down now. The natural reservoir of this organism has not yet been identified, but they suspect that it could be the food bat when it was transmitted to the primate, and human contact with these resulted in that outbreak. Symptoms we know are fever, weakness, headache, myalgia, nausea, abdominal pain. The problem, what causes the mortality is the hemorrhage and the fluid loss. Usually they were not able to keep up with the increased fluid loss, hence the increased mortality with that. Treatment is supportive care. There is no medication for that. Vaccines, no vaccines available as yet. They do have vaccines in production or in trial phases. They try them in Guinea, Sierra Leone. That in Guinea seemed to be quite effective, but nothing has been approved for that as yet. Then we have the Middle Eastern Respiratory Syndrome coronavirus. This was first identified in Saudi Arabia. It's suspected that it was transmitted from the camel to the human, and it's mainly a respiratory disease. Some people may be asymptomatic, but it is associated with acute respiratory failure, pneumonitis, multi-organ failure that also leads to death. Currently, it's usually transmitted from human to human, and all age groups are affected. It's diagnosed by the PCR in respiratory secretions. To date, according to the World Health Organization, 1,733 cases have been identified, out of which just a little bit over 600 died. So that also has a high mortality, and it is something we need to look out for in individuals who come from those countries, that's the Middle East and the Saudi Arabia belt, as well as some of the Asian countries, because there was an outbreak in South Korea as well. Again, no medication for that, no vaccine available for that, and just treatment. And we now know about the Zika virus, which was first identified in Uganda in a monkey in 1947. It's named after the Zika forest, which is where it was first identified. Currently we know about the outbreak going on in Brazil, but prior to that, there was an outbreak going on in the French Polynesian Islands. It is transmitted by the bite of the mosquito so it's a human-to-human transmission. That's what it is. That's what's going on currently in this outbreak. The main thing that has gotten us worried about Zika virus is the adverse fetal outcomes, the microcephaly, placental insufficiency, intrauterine growth retardation. So that's what's got us worried about Zika currently. Let's see. Majority of people are asymptomatic. About 80% are asymptomatic. They don't even know whether they've been infected or not. But when you are symptomatic, it's mostly a mild illness characterized by fever, rash, arthralgia, and conjunctivitis. Some people may have muscle aches or headaches, and it has a very low case fatality rate. It is associated with some neurological illnesses as well, thought to be associated with Guillain-Barré syndrome as well. Treatment, again, is mostly supportive. There is no medication available for that. There is no vaccine available for that. No local transmission in the continental US, but there is local transmission ongoing in Puerto Rico. And there have been guidelines issued by the CDC pertaining to pregnant women, couples who want to conceive, who have had possible exposure to Zika or are considering going to areas with ongoing Zika epidemic. Back again, continuing on tuberculosis, as I mentioned, it's still an epidemic. HIV is still an epidemic. There is no cure for that, no vaccines. There is eradication of polio in progress. They are hoping that by 2018, the world will be polio-free, and malaria mortality is down since 2000 when they came up with the Millennium Developmental Goals, but it is still an ongoing epidemic. Questions?
One question? Okay. You mentioned about telemedicine. So this seems like it's going to be a big thing in the future. Tell us what you think is appropriate to treat a patient over the phone on telemedicine, specifically UTIs, sinus infections, ear infections, and strep throat.
Now, some are relatively straightforward, especially UTI. The individual should be able to tell you that I have pain when I urinate. So that's something that can be done. And again, it will be good because you have guidelines regarding UTIs where you prescribe nitrofurantoin or Bactrim. And I would always start with those medications because those are the guidelines. And those tend to be relatively narrow spectrum, so that helps with that. When it comes to upper respiratory tract infections, though, that becomes a little bit of a problem. They come with sore throat. Again, you're looking for what is called the center. When it comes to strep throat, for instance, you're looking for the center criteria where they're having fever, they have the severe sore throat, they may have the tenderness. So when you have all those signs in place, then that helps guide whether you need to use antibiotics or not. So in a situation like that, it would be good for us to have guidelines in place so that you know that when the person presents with this cluster of symptoms, it's likely that they have a viral infection or they have a bacterial infection. So probably having guidelines, again, that something incorporated in the EMR would help with the appropriate prescription of antibiotics.
I have a very short question, okay? Have you heard of MAI, which is Mycobacterium avium intracellular? I had a patient who had it, a VA patient, and we, of course, saw him, sent him back to the VA. He was terribly septic, had large holes in his lungs. The question is that our infectious disease nurse was going crazy, saying everybody has to get a TB test.
No, the Mycobacterium avium intracellulare, it belongs to the mycobacterial class. The only organism in that class that you need to be on isolation for is TB.
Okay.
Anything else they do not need to be in isolation for. It's something that you can find in the environment. So based on the clinical symptoms, that's when we decide whether the patient has an infection from that or not. But they do not need to be in isolation for that.
And no TB testing at all?
No.
Okay. Thank you so much.
You're welcome.